Hi, everybody. Good evening. My name is Sean Hoha. I'm here as chairperson for the search committee for clinical track professor at USC. We have special guest as one of the candidates for that position, Dr. Pascal Magne from Geneva, Switzerland. He graduated dental school 1987. After he graduated, he started lecture at his school, University of Geneva, and he started lecturing over the internationally. Also, he was here, University of Minnesota, since '97, from '97 to the July 1999. For visiting us professor. And he became senior lecturer since 2000 at Division of Fixed Prosthodontic at University of Geneva. Also, especially, he got at 2002, well, it's hard to pronounce it, but Probat Dissent is pretty much equivalent to the PhD degree at the USA for teaching in restorative dentistry at the University of Geneva. Also, he has authored numerous books. So one of the special books, he had a bonded porcelain restoration in anterior dentition. Everybody knows it's a biomimic approach. Also, he has numerous lectures and articles, more than 50 articles. It's peer-reviewed articles. It's pretty much well-known to all the restorative dentists, also prosthodontists. Please welcome Dr. Pascal Magne for wonderful lecture for tonight.
I won't need it. I think, is this working? Yes, a little. Ladies and gentlemen, thank you for welcoming me. I can't say only today, but all these days. I was very fortunate to be here a little earlier than today to get used to the time difference. So now I feel full power to give you this lecture, and I hope I will be at the right level. I want to thank all of you for being here first. Today I'm learning something. You need to feed people also to fill the rooms, right? So we will apply that principle in Geneva because we don't use that enough. So please feel free to enjoy while I'm speaking. Okay, I was asked during this hour that we will spend together to speak a little bit about my research interest and academic interest. We'll try also to stay very well connected with the clinical material, because I think it's very important. So let me start. I'm going to jump over there, even though I don't like to be too high like that, but I have no choice if I want to change slides. So the title of my presentation will be slightly different from what was announced, and I apologize for that. The title was, I think, New Frontiers in Aesthetic Dentistry. Instead, I apologize also for the size of the letters, but you know, Switzerland is a small country, so we use small fonts, right? Sorry. So the intact tooth and the biomimetic principle as cornerstones of evidence-based novel restorative dentistry. I know it's a long title, and by the fact you can notice there is not the word aesthetics in the title, and it's not by chance, it's really on purpose. We just heard we did a book recently, a quite big book about aesthetic dentistry, but the word aesthetic is not in the title of the book. Because I must tell you, the word aesthetic today has become something maybe overused or used in the wrong direction, and I will explain exactly what I mean with this statement. So, a long title I will try to cover during this presentation. First, I must here make some acknowledgements. I would not be here today without the fantastic mentoring of Professor Erzbelzer in Geneva. He's well known in fixed prosthodontics, especially in implantology, and you might certainly have heard about him. He has been really my clinical mentor, and I must say I was very fortunate to have him in Geneva guiding my career. But also another person very important is at the University of Minnesota, where I spent 2 years and a half, was Bill Douglas, who I can call my research mentor or scientific mentor. And with this combination and this opportunity I had to be around these people, I must say that was the key element to my activity. And then I can't go without mentioning a third person here, who is also the same name as mine, you see, Magne, as you would say. We say Magne in Europe. And it's my brother, Michel, who is the owner of the Oral Design Center laboratory in Montreux. He's a dental technician, but also a master in dental ceramics. So we rather call him a ceramist, and you will understand why. So here is my brother. These pictures was taken a few years ago, as you can guess from the amount of hair. But one says that dental technicians always have more hair than dentists, which is absolutely verified here. And I think that I also wanted to have a little introduction here. You know, when we speak about what we do in work, I think it's always connected to what we have also in our heart. And you can separate these things. At least this is my opinion. And I don't know if you have heard of this person. He's a French philosopher, extremely famous, worldwide famous by the name of Jean-Paul Sartre. And it's very interesting because this man, Jean-Paul Sartre, was famous for his philosophy called existentialism. And I don't know if you've heard about that. It is something quite particular, which is summarized in this sentence. Man can will nothing unless he has first understood that he must count on no one but himself, that he is alone, abandoned on earth in the midst of his infinite responsibilities, without help, with no other aim than the one he sets himself, with no other destiny than the one he forges for himself on this earth. Please don't cry. This is sad, right? This is at least in my view, it is sad. And guess what? Jean-Paul Sartre became famous all over the world because of this thinking, this way of thinking. This is from L'être et le néant, being and nothingness, which is also well representing what this man was thinking. So you must think, but why is he telling us about Jean-Paul Sartre? We came to hear about dentistry. First of all, I told you, I think everything we do at work is also connected to things we have in our heart. This is related to something I have in my heart, and I will just show you this to start with, but this is just the beginning of the story of Jean-Paul Sartre. So I will tell you the end of his story, and now at the end you will understand why I told you about Jean-Paul Sartre. And in this way also I will make sure that you will stay until the end, right? Because if you don't stay, you won't know the end of the story. Okay. Evidence-based medicine, I think we all agree today, is something quite important. And I like also to just make sure that when we speak about evidence-based, we agree on what it is about. And Evidence-based is really what I have used as a nucleus to raise my research, for my clinical applications and so on. But I think it's important to have a larger view maybe of what we call evidence-based dentistry. And to explain what I mean, I just want to show you about this artist's work here. And let's see if we can learn something about evidence-based medicine from him. It was in the 1489. You see, that's very old. Was there evidence-based medicine at this time? And I think even though there were not the research tool we have today, there was a certain level of evidence that can be found in the life of this very famous artist. As you can see, at this date he was studying skeletons, even teeth, and watch these drawings of teeth. Then a little later he came up with the geometry of the Vitruvian man. I don't know how it translates in English. He studied the human head 2 years later. Later on, muscles of the mouth, very detailed descriptions. So this artist spent years studying the human body. You see another piece of work a little later, eyes and light distribution, muscles of the body, and so on. And I think it's not by chance, if it's only in this date, that he achieved this masterpiece. And I think that's very important to remember. There was no kind of evidence-based approach at that time as we have today. But to me, the way these artists evolved is very much like what we could call evidence-based, for instance, medicine. So Leonardo da Vinci, that's him, spent a great deal of time studying, and it also just puts forward the idea that evidence-based medicine, yes, but also a clinical experience, and that should be never separated from each other. So let's start a little bit to speak about teeth now. And especially one element I want to bring forward now, because this is the field I'm in, it's fixed prosthodontics. And I think that fixed prosthodontics has changed in a major way these last years. And just to give you a taste of what's going on, I want to share with you one case of our student clinic. This tooth is now a restored tooth of one of my undergraduate students. And it started actually like that. And as you can see, we have a root canal treated tooth with quite an important loss of tooth substance within the crown. And I'm just thinking to what I was doing as a student about 13 years ago in a case like that. And I think you can all make a treatment plan for that. A new root canal treatment, a post, core buildup, and a crown. So you make the addition, all these procedures, the time they require, and also the bill that it corresponds to, right? Today, we have learned to use bonding technology, adhesive restorative techniques, and this is how this case was solved. Using a partial coverage with bonding, you see that a very major part of the tooth could be kept intact. Only what was missing has been restored using a partial piece of restorative material, and you see the restored tooth after the placement of this adhesive indirect made restoration. You see the baseline and now the postoperative view, and now you can imagine everything that was saved through this treatment. That means no post, no need for a core buildup, for periodontal surgery, and a maximum maintenance of tooth substance, which we know today is a key element in the long-term behavior of these root canal treated teeth. So you see, with this kind of approach, and on the other side with implant dentistry, the question now, and that's why I really said the changing face of fixed prosthodontics, the question is what remains for the traditional full crown coverage. When a tooth is too good to be extracted, we use bondings to restore it. When a tooth is too risky to be restored, we extract it and we place an implant. And it's not that we can even cut full crown coverage for bridges, because these bridges have decreased while the techniques for implants have increased. So it's something we really need to think about because, for instance, in the last year of undergraduate studies, our students have great difficulties finding patients to cut a full crown coverage for their final exam, because most of these patients have been restored either with bondings or with implants. So things are changing a lot. And so we'll speak also about anterior teeth. Here there is another kind of restoration that has evolved, and it's all the bonded ceramic type of restoration. You see here a case of porcelain laminate veneers. This is the same patient before, after, and I like to say that these kind of treatment cannot be called aesthetic treatments anymore, because they represent much more than simple aesthetics. You see there is one non-vital tooth. There are aesthetic problems that have been addressed, but above all, we have addressed a mechanical problem, a functional problem, and we have respected the biology of these teeth because of the very conservative nature of these restorations. None of the pulp present under here have been endangered or lost, of course. This is the kind of restorations that has been used. Fingernail type of porcelain restoration, using only the principle of bondings to have them hold on these teeth. And the same patient, of course, you can imagine before, after, a major impact on the social life of this patient, which is also very important to mention. So in my title, I mentioned the cornerstones of evidence-based novel restorative dentistry. What is responsible for this huge shift in the way we restore teeth today? The first thing I want to mention is the understanding of the intact tooth. I think that that's a starting point. If we want to develop new restorative techniques today, we need to understand what's going on with the intact tooth, and then use that to apply what I call the biomimetic principle. I will explain later why I don't call these biomimetics, but the biomimetic principle. So let's start first to speak about the intact tooth. Now we have here a patient who is about 80-year-old. Watch his teeth. Watch the enamel surface. You see all these cracks. You see all these defects. Now I am asking you, is it a success or a failure? What would you say? 80 years old, that means about 70 years of function, service, chewing. It is successful, I can think we all agree. Now, if you see in one of your porcelain veneer restoration, if you see one of these cracks here, is it a success or a failure? That's a big question, right? Most of us would say that's a failure. if I have a crack in my porcelain restoration. But it's not a failure if I have a crack in enamel, right? So there is something we need to work at in the definition of a failure, because we could be more demanding for our restorations as we are for teeth. So let's see, why is that a success after 70 years of clinical function? And for me, a success I can define at least by putting together these 4 elements. A biological success, that means in this tooth, I still have what I call the driver of the tooth. That means a pulp, alive, working, functioning. There is a mechanical success because these teeth are mechanically efficient in the mouth of this patient. Functional success, and also an aesthetic success. That goes all together, and I think this is for me the definition. Of course, I'm not a biologist, so I'm going to tell you a little bit about mechanics and function, which is a great part of this success of teeth. Let's start with mechanics. As I said, we need to understand how teeth do work mechanically if then we want to be able to apply some principle to reproduce that behavior. And the first things we can say about teeth, they are made of 2 completely different materials. Dentin, first, is a resilient material. It is a little bit like plastic. It is, we all know, absolutely not wear resistant, as we have dentin exposed at the oral environment, and to function, it creates immediately defects and concavities at the surface of the tooth. It's not wear resistant. The opposite is enamel. It's exactly opposite behavior. It's very brittle, whereas dentin is very tough. Enamel is brittle, but enamel is extremely wear resistant. So you see, these materials taken apart have no interest. But it is the perfect association of these 2 that makes the tooth function as a whole for a lifetime. And when I say the perfect association, I mean through the dentin-enamel junction. The tooth is not a simple laminate of enamel over a dentin core. We will see that there is a complex fusion that occurs at the dentin-enamel junction. And this is why enamel and dentin taken apart would never function in a mouth. The tooth would never function as a whole if there was not this perfect fusion at the dentin-enamel junction. Dentin is very important, as I said, because of its resilience. You see here a tooth without its enamel shell. If I apply a load on this tooth without enamel, 5 kilograms, 50 newtons of load, and you could see it bend with your naked eye because the movement is about 1 millimeter. We know that this resilience is extremely important to the behavior of the tooth. We know from biomechanical studies made in United Kingdom by these authors that the stiffer the coronal part of the tooth, the higher the risk of a root fracture. So we see that a lot of what we have been doing in fixed prosthodontics, especially when doing these strong metal ceramic restoration, full ceramic restoration with this high strength ceramic, we have been increasing the coronal stiffness and also the risk of these root fractures. So the question now is, shall we continue in this direction where everybody is convinced that stronger and stiffer is better, knowing that the tooth is exactly not like that? The tooth is a perfect balance of resilience and stiffness. And this is through the association of this resilient, flexible core, dentin, and its rigid shell enamel that gives the perfect amount of stiffness that is required. As I said before, the tooth without enamel will bend easily under load. This is too floppy to function in the mouth. But with the correct amount of enamel perfectly bonded to it, then we have a modulated resilience. All this can work only at one condition: the fusion at the dentin-enamel junction. And I think there are lots of people here who have worked to understand this fusion. For instance, we know that the dentin-enamel junction is not a flat surface. It is much more complex than that. It has some little waves. In a 3D view, it would correspond to like a honeycomb structure with cells. And at the edge of this crest, you see these collagen fibers emerging at the crests. But if you go to the more detailed view here, inside this line, you will see other collagen fibers being associated in what we call microscallops. These fibers, they go from dentin to enamel, back to dentin. Is a very complex network. I don't want to extend too much. This is not only a drawing, it's a reality, as was showed by this work by Lynn Douglas Erlandson, in which you can see these collagen fibers doing these thick bundles coming from enamel into dentin, back into enamel with these little loops here. The dentin-enamel junction is a fiber-reinforced area of the tooth. And there is no better fiber reinforcements that can be described when we look at the dentin-enamel junction. So what is important to remember at this stage is the DG is an interface, like Zorro, and not an interface. And that's very important. If the DEG was just an interface, the strength of this bond would never be the same. And we'll see later why is it so important to understand that fact. There is interpenetration, interdiffusion of material between dentin and enamel. The dentin-enamel junction is the most complex part of the tooth in my view, especially considered in a mechanical point of view. If you remember what we have studied in tooth formation, what is the very beginning of the tooth? It doesn't start at the surface of enamel. It doesn't start at the pulp. The tooth really is growing from one side and the other of this dentin-enamel junction. And it's like if the divine architect had planned it in the perfect way, because this junction, being the most complex part of the tooth, had to be, let's say, engineered at first. So let's talk now, because it's important to come back to the main focus of this presentation here. Now we want to apply what I call the biomimetic principle. And why did I say the biomimetic principle? It's important. The word biomimetic is something really that has spoken to me. And the first time I saw it was mentioned by Bill Douglas at the time I was in Minneapolis, but it was in this publication by Dean Slavkin, Biomimetics Replacing Body Parts is No Longer Science Fiction. So biomimetics is something well known to the researchers in medicine, and I think it has become something very big. Now it's being applied, and we hope in the future, I don't know the time frame, but we hope we have the same applications, replacing body parts, replacing teeth, fabricating teeth or tooth germs in vitro and having them implanted and growing in the mouth like the first teeth we had. I think that's going to be a reality. But today, we still need, before we have these biological solutions, and Hal, you always say we need to find biological solutions to biological problems. Awaiting this moment, we still need to have mechanical solutions, right? I look forward to this day, but tomorrow when I'm in my practice, I need to use mechanical tools to have these biological problems fixed. And this is why I would not pretend to say we are doing biomimetics, but we can use the biomimetic principle to influence the way we are going to make our very mechanical dentistry. And to make that thinking process with you, let's ask ourselves the question, what materials are currently available to simulate enamel, dentin, and the DG? This is very important. If we ask ourselves this question, not only we might improve the way we do clinical dentistry, but we might find in which direction we could go in material science to improve these substitutes or the current substitutes we have. So this is why I want to present you some numbers here. I don't want to be too boring with tables and numbers, but there are things we need to know even as a dentist in his own practice. You have lots of manufacturers providing you lots of material, and you need to know a little bit about the properties of this material before you know what to use them for. So there are properties here that are mentioned: elastic modulus, thermal expansion, ultimate tensile strength. These are only a few of these properties to describe a material, but let's see what do we have for the simulation of enamel dentin and the dentin enamel junction. Enamel, we know, is a stiff material, elastic modulus about 80 gigapascal. Is a material with a thermal expansion of 17, which is quite close to the tooth that is estimated at about 11. Is a material with a tensile strength about 10. Again, don't take these numbers as for granted. They have been obtained in a very specific experimental design, and you can't always compare them to others, but it's just to give you one idea. And now we need to find the closest material we have on the market. And I think we will all agree that if I have something like 60 to 70 gigapascal of stiffness, a thermal expansion between 13 and 16, and an ultimate tensile strength between 25 and 40, I'm already above or further to what I need, right? So what would be this material in your point of view? This substitute. It's porcelain. And when I tell you porcelain, I don't mean the highest, strongest material on the market today. I am telling you about feldspathic porcelain, the very basic porcelain that the dental technician is firing over the metal framework. Something almost the weakest porcelain you have on the market today is still maybe stronger than enamel, especially as regards to tensile forces. Quite amazing. We have one little problem though with porcelain, and we will all agree on that, and we need to work at that. Current porcelain are very abrasive to antagonistic teeth, and this has really to be worked out. This is one area of research that is, I think, will be of great interest. But this is not what researchers, and most researchers in porcelain today, they are not working a lot at wear properties. They rather, and they still go strongly in the direction of stronger and stiffer. But now I'm asking you, is it really this direction that counts? Because you see that even the weakest porcelain on the market is still much stronger than enamel itself. So let's continue the process. Now I have dentin. Dentin is much more flexible, 14 of elastic modulus, about 11 of thermal expansion, dentin is the major part of the tooth in volume. So if you take the expansion of the tooth as a whole, you are very close to that number, which is the one of dentin. Dentin, as you can see here, has a very interesting properties, which is the tensile strength. Also, the toughness will be very interesting in dentin. It is something extremely tough. Why is that? Interesting. Why is dentin so tough? And if you think very deeply, dentin is the best example of fiber reinforced material. Dentin is also made of collagen fibers. And it is my deep conviction that these fibers have a huge importance in the toughness of dentin. Because if we take the closest substitute to dentin, which is the current composite resins, they have about the same elastic modulus as dentin, between 10, 20, a large range according to the product on the market. They have one little defect here, is the thermal expansion, because of the organic content, the resin part. The thermal expansion is still much higher compared to that of the tooth, and that can create problem when you have thick layers of composite under a thin layer of ceramics. Thermal loads can create tension in the ceramic up to cracks and such problems. However, another problem of composite, as you can see, is the tensile strength. We know also the toughness is a problem, and it's not very difficult to understand that current composite resins do not have fibers. The one you use to restore single teeth do not have fibers. And I think this is another great field of research that must be reached, is the fiber reinforcement, not only of composites for indirect prosthodontics, but also composites that we use directly in the mouth. And finally, for the dentin enamel junction, we have what we call dentin bonding. Now, is the current state of the art of dentin bonding something that is close to the dentin enamel junction? I think that's a very interesting question. Let's look at it. And all of you who've been involved with adhesion, you know that dentin bonding is obtained, that's the, let's say, current state of the art, through the demineralization of the superficial layer of dentin through an etching with an acid, and the infiltration of this collagen network. The collagen network will remain. It's like your hair on your head, and if you take care, this hair will not collapse. You keep it very loose like that in the air. So if you over dry the surface, it's going to collapse. You will have problems to raise that again. So it's infiltrated with a hydrophilic resin monomer, and then covered with a resin and a composite. And if you watch this current state-of-the-art of dentin bonding, you realize that it is actually reproducing very grossly the configuration of the dentin enamel junction, in the sense that we have collagen fiber very firmly anchored in the non-demineralized dentin. These fibers have been embedded in the restorative material through the hydrophilic resin and the bonding resin. So it's something very interesting, and I'm personally convinced that this way we do dentin bonding today is very, very close to what we can have with the dentin enamel junction, especially because this dentin bonding is not an interface, it is also an interface with an interpenetration network. By the fact, you all know that this layer, we call it the hybrid layer or interdiffusion layer, which is very close to what we have seen with the thick collagen bundles responsible for the strength of this enamel dentin junction. We need also to speak about function. This was a quick mechanical overview, let's speak about function. Not only we need to understand the mechanical aspects, we need to understand how these forces and stresses are going to distribute under a functional load. And one of my field of interest is the field of numerical simulation and finite element simulation. In a series of papers published in 1999, we tried to have a hybrid approach with experimental and numerical analysis to describe the behavior of anterior teeth. In this study, we just explored what could be the major parameters that make, for instance, an incisor work in the mouth of a patient, especially over such a long period of time. And we noticed that there were some very interesting differences. If I take the facial surface of an incisor, it's all convex, very soft. You see these little ridges, nothing to compare. And I take this facial surface and then I watch the opposite surface. You see these mountains, valleys, mountain. It's more like Switzerland here, right? So, and the cingulum, a very soft, convex surface. So, why is it that an incisor is made like that? Is there a reason to these thick proximal ridges, convex, concave, convex? So, the approach here was to have, as I said, a hybrid approach, using strain gauges in an experimental approach, using then finite element in a numerical approach, and combining these results and validating these virtual models, we could have a very nice understanding of the tooth mechanics during function. And I just will summarize here with these few images. We could recreate an anterior guidance in a situation of anterior teeth. So you see an upper incisor, the antagonistic tooth, and the stress distribution in the upper incisor. This image here will show you where are the compressive stresses in gray compared to the tensile stresses. Why is it so important to make a difference? As you know, dental materials and teeth are brittle materials. Most of them, especially aesthetic dental materials like ceramics and composites, are brittle. That means they can stand compression forces quite well, but they are not very good when subjected to tensile forces. And we need to know in a function where is the compression, where is the tensile aspect. This big tooth here, it will tell you the risk factor of a failure. It is called modified von Mises criteria, and it takes into account the difference between compressive and tensile, just giving you the higher risk of failure by the colors that you see here. So as you can see, when teeth are in maximum intercuspation, most of the tooth is under a compressive stress or a very light tensile stress, which is nothing really risky, let's say, for the structure. The challenge comes when we start going forward with the antagonistic tooth, because now, as you can see, the teeth start to bend. And now we have a vector of force that is perpendicular to the long axis. And because of this configuration, there is a bending of the crown. And we know that the bending means deformation, displacement means stresses. And you see that nothing much happens in this side of the tooth, which is now under almost a complete compression stress, but things develop in the palatal side of the tooth. And now we see in the concave area of the cingulum a concentration of stresses. Very surprisingly, in the area of the cingulum, a very quiet area, but in the concavity, in the fossa, a concentration of stresses. So let's go ahead and let's try to make a little more out of this research. For instance, now we know this is an upper tooth. Now it's upside down. You have the facial surface with the compressive stress, the palatal surface with the pattern of tensile stresses. Now imagine that I lose the facial enamel. Now I'm losing the thickness of facial enamel. This could be many things: erosion, wear, or just you preparing a facial laminate veneer, right? What's happening? Now you see the stress pattern in the palatal surface is changed dramatically. Now we have a complete, an increase of tension here. And we know that it's not so difficult to explain. We removed one layer of the stiffness, one layer of the material that gives stiffness to the tooth. Now the tooth becomes more floppy. More deformation means also more stress in the residual enamel. What if we could increase the thickness of enamel? In this other experiment, we just changed the palatal concavity into a palatal crest. This is something you can't do in an experiment. And this is one other aspect of finite element modeling. It will give you access to data and simulation that are otherwise impossible with experimental tools. So now we have a crest. And now it is not surprising. You see the influence of the design here. The tooth becomes thicker. So thicker means less displacement, more stiffness, especially when this stiffness is in the form of enamel. How does it look like to you, the tooth? Now, does it still look like an incisor? I don't know if you agree, but this looks more like a canine. And we know canines have this kind of palatal shape with a very soft convexity. It's like an overdeveloped cingulum that reaches the incisal edge. Is it by chance? No, it's not by chance. If a tooth like the canine with such an important guidance, it's the tooth at the corner, at the edge of the dental arc. This anatomy, again, is not by chance. It has its design and for a specific reason. But incisors are not simple concavities on the palatal surface. As you can see, there are these strong lateral ridges, right? And we have underestimated the importance of these ridges. And we see here that if I section the tooth in the center, I have a simple concavity. But if I section the tooth in the side, I have a crest now with a complete different stress distribution. This is why it is so important when we think about modeling to think in 3 dimensions, which required specific tools. These are only 2-dimensional simulations, but 3D simulations are very important in this regard. So I want to bring another element here, which is the natural history of a tooth. A tooth is not just one organ that comes into your mouth and stays like that for your whole life. It changes with time. So this is how it started. And we all have seen that in our children and nephews' mouth, these teeth with the fantastic crest, fantastic surface texture. This is the virgin tooth, let's say. Is it going to stay like that? Of course, we know not. During the whole life, there is enamel wear, progressive thinning, and cracking. We are back to the initial story of cracking. And this is ultimately how we will end up. This is a patient I treated 6 years earlier with these 2 composites here. You see the 2 cervical composites? Patient was worrying about these cervical lesions. They were very deep abfraction lesions, and I filled that with composite. Did I solve the problem of this patient? What was the basic problem of this patient? Basic problem was, amongst other, the loss of enamel. You see now she's back 6 years after, and you know what she's back? For aesthetics, because she says, now my teeth became more saturated, my teeth are yellow, especially the 2 centrals. Very interestingly, my composites are still here, but what you can read on the composite, especially if you see here, there is a marginal chipping here. And this is just telling us that these teeth have been suffering for all these years due to the crown flexure. This flexure was so strong that it could chip the margin of the composite, and this evolution will not change if I don't address the basic problem, which is the loss of enamel. So in a case like that, I love this patient because it is illustrating a very multidisciplinary approach to the problem of abfraction and erosion. We had also in the same patient a problem of an evolution of these cervical recessions. So the first thing to do in a case like that is to address the biological problem, the cervical recession. We did connective tissue grafts to stabilize the gingival contour and ensure the covering of the remaining part of the root. Excuse me. So that was the first step of the treatment, going from here to there. And in a second part, we addressed the more mechanical issue, the mechanical part of the problem, by replacing these defective, let's say, enamel layers with a new layer of ceramics. And we did that with the use of porcelain laminates. As you can see, the root surface was simulated using special effects in the porcelain, but you can imagine that the result that was obtained here is a combination of the surgical approach over the soft tissue and the restorative approach, giving to these teeth what was lost, that means this surface of enamel. So we must be really careful about surface wear, and I would like to say that the wear at the incisal edge is one thing, but it's not the type of wear that makes me more unhappy. The type of wear that I fear is also the wear at the facial surface, and we must keep an eye on this. It's going to influence a lot the way we restore these teeth. And we know that by losing this surface enamel progressively, we are losing stiffness. There are aesthetic problems related to that, dentine exposure, staining, etc. But we should never forget the basic root of the problem, which is also a mechanical aspect. So, as you can see from these plots here, the loss of enamel increases the focal stresses. This is the focal stress in the palatal fossa. And when you build back enamel with material that is close to it, here ceramic for instance, you restore the original pattern of stress. So that was the lost enamel restoration. And now let's compare the natural tooth and the restored tooth. The natural tooth and the restored tooth. And this is what I call the essence of the biomimetic principle in restorative dentistry, is to have a restored tooth that behaves like the intact tooth. And we see that when we use porcelain to replace enamel, we can achieve that principle. What if we use composite? So now compare the composite veneer with the natural tooth. Of course, there will be always a difference because the composite is not an enamel-like product. That means the original pattern of stress is never reached, and the tooth remains a little more flexible. And there is an interesting work here in Minneapolis that was published in '94 by the fellow by the name of Ree and Ross. They could show, again, in a hybrid approach using strain gauge and finite element analysis, that the composite veneer could never really reach the level of the ceramic veneer in terms of stiffness. So we never reach the level also of the intact tooth. We have other works I could not mention here that show that the ceramic veneer can not only reach the level of the tooth, but maybe go further and make the tooth crown even stiffer and stronger than the intact tooth. So as a result, when you don't respect the biomimetic principle, now you have a higher risk of cracking, This is a sample with a crown that had an increased flexibility, and you see after testing, you see all these cracks. What do we know about these enamel cracks? This is the corresponding sample in the strain gauge study. You see these enamel cracks located exactly in the area where the finite element model predicted the maximum stress. What we know, fortunately, is that by having cracking, now the stress is not anymore at the surface of the tooth in the enamel layer. It is now focused in a deeper structure. And where is that? This is the dentin-enamel junction. Fortunately for us, this junction can withstand these stresses due to the structure that we have seen before. Interestingly enough, we know that as long as the bond will survive, enamel will stay attached to our teeth, and we can be very happy of that, because all of us in this room have cracked teeth, but we don't have pain because enamel is still well attached to dentin. And we could say maybe the same about restorative materials. Watch this article published by a colleague, I won't pronounce his name here, Austria. He said, he showed this case at 7 years of clinical service. You see 2 porcelain laminates with full of cracks. And it's really interesting to notice that not one piece of porcelain has left the tooth. The bond has survived. We know this was bonded to enamel. Enamel bonding is extremely reliable. We know that. And you see that even though they are cracked, they are still here. A little bit like the intact tooth, right? So for me, this is the fantastic biomimetic principle that can be achieved with porcelain veneers. And in my view today, it is one of the best restorative approach when used adequately in the proper indications that can restore a tooth and make it work like an intact tooth. So let's remember, enamel is essential to the balance of stress. It gives the stiffness by its thickness. So there is a balance between facial, palatal. We have seen the distribution of stresses. The functional stress are so that in an upper incisor we have compression at the external surface, we have tension at the palatal surface. What about inferior teeth? So you can see from this simulation it's exactly the opposite. Now we have compression in the lingual and tension in the facial due to the opposite loading pattern when simulating this guidance and functional movement. The palatal fossa is a very interesting area. It creates a sharp incisal edge due to the geometry, and we know that the sharpness of this incisal edge allows the basic function of an incisor, which is cutting efficiently. But it is an area with thin enamel, high tensile stresses. And the good news is the concavity is not alone. We have 2 marginal ridges here, and these marginal ridges along with the cingulum are areas with stress distribution. They are convex instead of being concave, and this is not by chance again, and they represent by the fact the vertical dimension stops. So I think that we can now understand why are porcelain laminate veneers so good when you watch clinical papers, clinical studies about them. Because most of these veneers are placed in the facial surface of upper teeth, which is an area mainly subjected to compressive stresses. So the ceramic will not be harmed anyway. Enamel, when lost by erosion and wear, causes unbalanced stresses, and this is one, I think, of the most important conclusion of this work here, that when you lose enamel, you must restore its thickness with material able to restore the stiffness, and we know for enamel it is porcelain. So now what about some other issues like bonding to dentin? And I want to just raise a few works here, one of these about the way we need to bond to dentin. We know today that current dentin bonding agent can be used in different ways. It's not only a product, but there is a method behind it. And I have found that even teeth with extensive dentin exposures, like this one, in this case you can see that most of the surface prepared in yellow you see is dentin. The remaining part is enamel, but only the little ridge that you see on the proximal and incisal area. This is the same patient I have shown you before. Can we bond efficiently to this? And today there are some very interesting answers. The answer is yes, we can bond at the condition we use the dentin bonding agent the right way. One very important aspect, we need to seal dentin before we take the impression, because this is the best kind of bonding we can have. I don't have time here to explain all these details, but that was just to raise the issue of bonding. It has evolved. Another issue is, what about non-vital teeth? I mentioned one case of posterior teeth beginning this lecture. Can we apply these principles in anterior teeth? Yes. You see a decayed tooth. The distal aspect of the tooth was the most decayed. There's a composite buildup and a laminate veneers covering this tooth. It's a case now in which we have a 3-year follow-up. Non-vital teeth can be approached also with these same techniques. We did impact testing. That's a very interesting work. We compared endodontically treated incisors to endodontically treated incisor restored with dentin bonded veneers. And that was one little pilot study we didn't publish, but just to give you an idea of the strength that can be reached using traditional restorative material like feldspathic porcelain and composites. Watch the fracture pattern after an impact testing on the incisal edge. And let's compare the non-vital incisor without a veneer with the non-vital incisor with a dentin bonded veneer. Is it a realistic test, first of all? Watch this case. It's taken from a book by a colleague in Brazil, and you see a tooth with very bad proximal restoration and a crack. Where is the crack? In the concavity. Is it by chance? I don't think. We know it is a high stress concentration area. How did it propagate? Exactly like in our little pilot experiment of impact testing. What is really interesting here is to see how did the crack propagate. You see the natural tooth, non-vital, it's a very smooth curve. Watch the tooth restored with a veneer, and you see the margin of the ceramic laminate here. It does like a Z. It's like the crack is trying to avoid the porcelain. And knowing that this tooth restored with the laminate veneer was hit at its incisal edge with a hammer, it didn't crack at all. There is no damage into the restoration, but a big piece of dentin was ripped off the tooth. So now maybe we have gone too far in restoring these teeth. They are too strong, even though it was originally thought that these dentin bonded veneers didn't work. So there is a whole world that is opening now. We know that bonding is the key. If you have a ceramic veneer that is not well bonded, this is the kind of failure you will see. Now, the tooth is left as it was before to place the veneer shattered in pieces. Maybe that's the way we should go. Having restorations that can hold function, but maybe under a very high stress peak that can debond and separate, leaving the tooth substance intact. That would be the restoration of my dreams. Because when restorations are too well bonded and too stiff and too strong, we know that in an impact situation, an acute situation, we might lose a significant part of the intact remaining tooth substance. So this is also something we have learned from the automotive industry. We know that we need structures that can fail to protect the driver in the car, and the driver in the tooth is the pulp. So we need structures that can fail. That's also important to consider. So I will finish with this case. in view of all these researches, we have improved a lot the way we use bonded porcelain restoration. And this is one extreme example I want to share with you. The patient had fractured her incisors. And one of these fractures, you can see, was almost at the level of the papilla with an oblique path like that. What did we do? We just prepared the remaining facial surface with a pellicular elimination of enamel, and now we have a restoration like a fingernail that comes over the remaining part of the tooth but restores the missing part of the tooth. Would you do that just trusting bonding? Imagine this patient, if you are the one that says, no, I don't want to know about these bonded porcelain restorations. Now, what options do you have to restore that case? You can go with composites and direct application, but you all know that composite is not going to behave well in the long term when restoring a full incisal edge with a large incisal edge span like that. Now you can go with traditional prosthodontics. Now the next question is, how do you want your crown to hold on that remaining substance? You will need to make a root canal treatment, a post, a core buildup, and a crown. So I think now we cannot go anymore without these bondings. In this case, as I said, we did these restorations, which illustrate exactly the advantages of this bonding, which is first, biology. Biology has been respected because we could maintain pulp vitality, because we know that the biological structures around the restoration, the gingiva, the periodontium, are well respected. There is evidence about this in regards to bonded porcelain restorations. Mechanically and functionally, we have teeth that function almost like intact teeth. And this will be my conclusion, aesthetically, I have made a number of different restorative techniques in my short career, composite, crowns, with all kinds of ceramics. But I can tell you, only these bonded porcelain laminates could give such a result if you compare the direct light, the indirect light, the fluorescent light. Only this type of restoration could be seen with all types of light in 3 dimensions and give such a nice aesthetic result. Of course, this is not only the technique, the method, this is also an outstanding dental technician behind this. This is my brother. I think this is also a whole field that needs to be developed, is dental technology. I wanted to tell you more about this. My time is over, but there is a whole way of fabricating these restorations to make them look alive like that. And there are also principles in aesthetics that can be very scientific and very rational. And I'm very grateful to my brother for having shared with me until now all his knowledge about aesthetics. It's not an artist's work. It is more a craftsman's work, and it is less artistic than we believe. So this is the final situation, and I promised I was finished with Jean-Paul Sartre. So you all stayed here today, and I think it's a very interesting conclusion now. I told you that was the whole life of Jean-Paul Sartre was existentialism, very limited and sad approach in my view. But what very little number of people know is that Jean-Paul Sartre, even though he had been building his towers of fame, of glory, on existentialism, there was one little thing that changed. When Sartre was lying over his deathbed, suddenly he started to think differently. And suddenly he changed his mind. And he said to his closest friend, Pierre Victor, who was another philosopher who functioned also as his secretary at the end of his life, he said to Pierre Victor, you know, Pierre, I do not feel that I am the product of chance. a speck of dust in the universe, but someone who was expected, prepared, prefigured, in short, a being whom only a creator could put here. And this idea of a creating hand refers to God. He had spent his whole life denying the existence of God, but everything was different when he was on his bed of death. And I think this is just also to tell you we are not alone. I think that in what I have showed today, it's all about teamwork, team making. You have a fantastic dean in that regard who is really a team player, and that's also why I'm here today, and that's why I visited you. It's really outstanding to know that USC is going in this direction. Team is also the core of my work. I think I wouldn't be here without the team I have presented at the beginning. So we are not alone, abandoned. No, we are playing in a team, and the only thing I can say to conclude is God bless you all, and thank you for your attention.
Okay, before we adjourn, anyone has questions? Okay.
You started your presentation, which was wonderful actually, by perfection of dentin enamel junction. Dentin goes back to 600 million years ago with Trachodon, and we even didn't have enamel. And actually it would be a disaster for the trachoderms and placoderms both, because it would prevent them from getting information from outside and transferring that to their nervous system, which was critical for the survival of those animals. And then it seems that your approach is a very much is a divine approach, as you mentioned that. And I really don't think that perfection is our goal, because going back to Leonardo and Jean-Paul Sartre, I don't think that's either of them was advocating that, because that would be truly the end of life. Order and perfection and symmetry. What makes the life beautiful really is the creativity. And that's why aesthetic is very proper terminology actually, because that's a word which requires a dynamic definition at all time, which fits this notion of actually this last statement by Jean-Paul Sartre, creativity. But of course what it is we don't know. That's why we come to school to, as you mentioned, to work together. But that's something I wanted to.
That's a whole philosophical debate. I mean, that's well beyond the scope here. But I agree with you. My intent was not to give one only explanation to the whole story. It was just also to show that only stupid people can't change their mind, first of all. And I think Jean-Paul Sartre is one marvelous example, even though most people don't know about the end of his story. It was to tell you about team, as I said. It was also to tell you about somebody well beyond our little thing that we see in this world. And I think you might be right. I understand you mentioned the name of dinosaurs.
No, trachoderms.
What is that?
Trachoderms, they had a very heavy body, so they had a hard time to move.
Is it a pre-human stage that you mentioned? What is that?
That's a difficult question. It happened 600 million years ago.
Okay.
600 million years ago.
So there might, I mean, if they didn't have enamel, as you mentioned, there was a reason. It was very important for their life. We know
that I understand. If you would say that enamel joined dentin,
yes,
and that was a beautiful accident.
Yes.
But that accident didn't happen to begin with.
And I think everybody of us would agree that if we didn't have enamel, And some people know that, the bulimia patients and all these, they know about not having enamel, what it represents. So I think, as you said, there is a divine preparation here that has been made, and it's not by chance. If we have, and maybe there was not 6 million years ago. Yeah.
Pascal, I just wanted to compliment you on your new book, and the photography is magnificent. And I was just wondering, how much of the photography that you showed us today was done microscopically? Was any of it?
No. This is all high magnification macro photography. Yes. Mm-hmm.
Thank you.
Of course, except for the SEMs and these. Yeah.
Okay.
I don't have yet the camera to do that. Yeah.
There's no further question. On behalf of the. Okay.
Pascal, thank you very much for a lovely presentation. In terms of sort of futures-oriented R&D, are any of the companies investing in the idea of mixing materials in the interface between developing a class of ceramics that could mix in a phase language with the demineralized dentin
Right.
surface
Right.
to get
Right.
the
Right.
quasi-dentin-enamel junction physical properties.
Right. Right. We were speaking about that this afternoon with Professor Maduka, and that was it's a whole field. You are absolutely right. My point was here to say we have a huge amount of researchers working on strength, stronger, stiffer, but nobody working on other aspects of ceramics. That one would be the wear properties I mentioned, the other one would be the self-adhesive properties that could be developed, and I don't know of many research, neither companies working at that, but that would be a great pole of interest. There was one lady in Minneapolis when I was there by the name of Sarah Efland, and we published in an article about bioactive ceramics with the hope that we could have like a ceramics that could grow into the dentin collagen network to achieve bonding without intermediate material like resin and composites. And I agree with you. We tried to go in this direction. Unfortunately, there was not much going on after this work. But that's one thing to work at. Yes.
Did some beautiful finite element analysis on the sexual sizes when you're talking about the sexual extension. Is it your premise that form and solid function in that evolution in the way that you're describing the morphology and the concavity of the sexual sizes?
Absolutely. I would not say evolution. Now you use a strong word here. I was not there to tell you how it was before, but I can say today that form and function is absolutely related. And when you see the form of a central incisor, if it was only for mechanics, the central incisor would not have a concavity. It would be, there is a much stronger design if you look at canines. And we don't have canines here. We have incisors. We need that concavity to cut, to make a sharp edge. But it is mechanically weaker. But again, the design is so perfect because the tooth is not only a concavity, it has ridges. And how many times we have underestimated the importance of these palatal ridges, which seems to act like the suspension of the Golden Gate Bridge, right? And the canine has a different shape, a different function. If you take a premolar, you could just envision that the premolar seems like you take two canines and you fuse them together. You get these features of a premolar, a very convex cuspal internal slope. The facial surface of a premolar is very like the facial surface of a canine, very much like. So yes, there is form and function relationship. I'm sure about that. Mm-hmm. Mm-hmm. Uh-huh. Right. Yes. Mm-hmm. Mm-hmm. The canine is a very versatile tooth because it looks, let's say, alike facially and lingually, much more than an incisor. So, and if you take an upper or lower incisor, you have like a biconvex shape that reminds me the Roman arc, you know. So it's a very strong structure, either up at the upper jaw or the lower jaw, because of the more symmetrical aspect. And by the fact that you see the roots of a canine, that's also one thing that really is striking when you think about function. Yeah. Yeah. Mm-hmm. Right. Right. Thank you for asking the question. I forgot to mention this aspect. These simulations did not include, for certain of them, did not include root, the PDL, bone, which we could think, but it's not realistic. You need to know what was simulated here is a little bit like a car without suspensions and with wooden wheels. So we were fixing the root at the cut plane. So the root was really rigidly attached. So everything that happens here is a little stronger than what could happen in a clinical environment. And our goal was to get a little bit the maximum challenge for these teeth. So we could say, yes, you're right, simulating the whole could be slightly softer. But we spoke also about that with mechanical engineers, and the difficulty being is that the PDL is a very complex structure. And if you take a finite element model and you want a model things like a PDL, then a large structure like a tooth, you need extremely powerful tools to be able to accommodate some very microstructural elements with more macro structural structures. So I didn't do that in this work, and thank you for asking because it allows me to explain that now. Yeah.
Okay, I think there's no more questions. Thanks again for coming here, and on behalf of the USC School of Dentistry, thank you, Dr. Magne, for a wonderful presentation.
Thank you very much.